I guess I can kick things off. We're a couple minutes past, so the numbers started going slower. So, um, hello everyone. I am so excited to share one of the lovely people that I had the pleasure of working with. Um, Nicole Marshall works at the Skin Surgery Center. I worked with her there for about 6 years. So in addition to being coworker, she is also the person who does my skin exams, and she has for about 10 years now. She's going to share some lovely information with us about sun protection and skin cancer, and I will let her take it away.
Thank you, Corey, and thank you everyone for listening to me today during your lunchtime. We're going to talk about skin cancer, some of the risk factors, the most common types of skin cancer, how we remove them, and then most importantly, how we prevent them. And since this is a lunchtime talk, I did remove the surgical pictures. So that section may get a little boring, but hopefully no one ends up losing their appetite. As some of you may know already, skin cancer is very common. It's actually the most common type of skin cancer. Even if you take the other top four skin cancer or other four cancers, breast, prostate, lung, and colon, there's still more cases of skin cancer per year. So it's very prevalent. The good news is that we can do a lot to prevent the biggest risk factor, which is UV radiation. About 90% or even more skin cancers are caused from UV radiation. And so that's why we'll talk about sun protection in a little bit. But another big component of UV radiation is tanning beds. So if you take nothing else away from today, if you are using tanning beds, your kids, your grandkids, whoever it is, they are a huge risk for skin cancer. Even just 50 times in a tanning bed can increase your risk of melanoma by about 75%. So it's pretty important if you aren't already if you haven't already stopped using them. I don't care what they say about this one's healthy or not, none of them are safe for your skin. So that is an important risk factor that can be easily avoided. Other risk factors for skin cancer: viruses like HPV, if you've had a history of radiation treatments, smokers, there are certain genetic conditions that predispose people to skin cancer. Severe skin trauma like burns, certain chemicals, or anyone that is immunocompromised is also at a greater risk for skin cancer. In addition to that, our skin type also plays a role. So those that are fair skinned with blonde hair, blue eyes are going to be more prone. Anyone that burns easily. If you have a history of excessive sunburns, and that's especially important in childhood, we do most of our damage before age 20. And unfortunately, a lot of that just catches up over time. That doesn't mean that at a certain age you don't have to worry about sun protection, but especially those early years are really important for sun protection. And then if you've had skin cancer in the past, that will increase your risk of an additional skin cancer or having a family history. So what are the most common types of skin cancer? Melanoma is often the one you hear most about because it can be fatal. So you definitely don't want to miss that. Much more common, though, are what we call non-melanoma skin cancers, and that can be basal cell or squamous cell. Basal cell is by far the most common. There's almost 4 million cases a year that are diagnosed for basal cell. The good thing with that is they are slow growing. So as we're talking through today, if you feel like, hey, I've had something like that, definitely go in and get it checked. With basal cells, often the textbook definition is a pink pearly papule. So I'll tell patients, if you feel like you're getting a pimple, but it's not acting like a pimple, it never goes away, it grows, it bleeds, anything like that needs to be checked out. And there's a few different subtypes of basal cell. The most common is nodular. You can see in that picture kind of that pink pearly look. These also bleed very easily. So if when you're washing your face or you're shaving, there's always one spot that bleeds, that would be worth getting checked out. These pigmented basal cells are much less common, and typically in still fair-skinned individuals, but more with kind of brown hair, brown eyes. These can look a lot like melanoma, even to the trained eye. So most people would get these checked out, but good to be on the lookout for kind of a new dark brown spot. Superficial basal cells are a little more subtle. These just look like a little pink patch, so they can be ignored for quite a while. They don't really jump out. But if you have noticed a patch that's pink, again, it may bleed when washing or shaving. That could be potentially a basal cell. And then the least common is morpheoform basal cell. And these are very subtle. They have more of a scar-like appearance. So if I'm seeing a new patient and I notice something that has a scar-like look, I always ask about history. Do you have a chickenpox scar here? Any trauma to the area? And if not, that increases my concern that it may be a morpheoform basal cell. These do tend to be the most aggressive, and they tend to have what I call an iceberg issue, where what you see on the surface is not the whole picture. They can end up being quite large surgeries. And so with these, Mohs is definitely warranted, and we'll get into that later on. Squamous cell is the second most common type of skin cancer. There's only about 1 million cases per year, but that's still quite significant. And there's just a couple little subcategories for squamous cell. The early or superficial type of squamous cell is called squamous cell in situ. So anytime you hear in situ, you can kind of equate that with early. It means it's just in the upper top layers of skin and it hasn't become invasive yet. And these will kind of be red, scaly, sharp edges, again, slower growing. Invasive squamous cell, on the other hand, can grow quite rapidly. These tend to be more of a tender bump that grows quickly. So anything like that, you definitely want to get checked out. And squamous cell actually can metastasize. It's less likely than with melanoma. And when we do a biopsy, we'll see features under the pathology or in the pathology that tells us whether or not it is more of an aggressive tumor. But with these tender growing, you definitely want to get these looked at. And then keratoacanthoma is an interesting subtype of squamous cell. They do grow very rapidly, but as I describe them, they grow more outward than inward. So you still obviously want to get them removed, but they have a lower risk of metastasis than a standard invasive type of squamous cell. So we've covered the two most common cancers. How do we get rid of them? You can see there's quite a few options for removing skin cancer. The first one, cryotherapy, is also called freezing. So we use liquid nitrogen. I use a lot of freezing and liquid nitrogen for precancers or superficial growths we call barnacles sometimes, or warts. I prefer not to use it for skin cancer. You have to do a very hard freeze that leaves a big blister. The scarring is not ideal and it has a pretty high recurrence rate. So sometimes it's the only option, but it's definitely not my first choice. The next one, electrodesiccation and curettage. We sometimes nickname the burn and scrape. With this, we just, as it says, kind of scrape and then cauterize the residual cancer cells. It's good for earlier skin cancers, not on the face. It does leave more of an open sore, and scarring can be hit or miss. Sometimes they heal really well, other times they do leave more of a wide scar. But for really active people, it's a nice option because you don't have all the downtime, the restrictions of a big excision with stitches for multiple weeks. Radiation is an option for people that aren't surgical candidates. It often involves numerous visits, like daily for a few weeks, so that can be challenging. They also have similar wound complications to surgery, and the recurrence rate, at least in my experience, is fairly high. But again, if someone is not a surgical candidate, it can be a good option. Topical chemotherapy I use quite regularly. These are nice because patients can do it at home. It's just a cream you put on once or twice a day for about 6 to 8 weeks. It causes a big inflammatory reaction, so it can be kind of red and tender for a while, but it saves you a big surgery. So that can be nice for superficial cancers. Photodynamic therapy, similar to freezing, I like for precancers. It's not used as much in the US for treatment of skin cancer, more so in Australia. And again, for superficial skin cancer, it's reasonable, but not usually my go-to. The surgical excision is commonly used, especially in our office because we're surgical specialists. Any invasive tumor, it needs to be surgically excised just so it doesn't come back. And usually with that, you're going to have stitches for a week or two. There is some downtime associated with it, but that's the best way to get rid of kind of more invasive squamous cells or basal cells. And then Mohs is what our surgeons specialize in. Not everything's going to qualify for Mohs. It has to be tumors that are either really aggressive based on location, like face, scalp, hands, feet. It's nice. It has a very low recurrence rate because of the way they process the tissue. We look at it under the microscope. And it's also what we call tissue sparing. So it allows us to take a very small margin and we do it in a stepwise fashion. So you can imagine if you had a basal cell on your nose where you don't want a big scar, you definitely don't want to have to deal with it again in the future. Mohs is the best option. Now melanoma. So far less common than basilar squamous cell, but still about 1 in 50 people in their lifetime will experience melanoma. And I often hear, being on this side of the mountains in Seattle, we don't have to worry about skin cancer. It's cloudy all the time. And that is a big misunderstanding. We actually have a very high incidence of melanoma, as do a lot of the more northern states. So it can be deceiving, even on those gray days, how much UV is actually getting through. And then melanoma does unfortunately affect a lot of younger patients. Quarter of the cases are in patients under 45, and it's the leading cause of death in women for cancer death, aged 25 to 30. So definitely something you want to be on the lookout for. And what we educate people on with melanoma are the ABCs. And this is usually in reference to more of a flat brown spot. You want to look for things that are asymmetrical. B is going to be its border, so anything kind of jagged or irregular in shape. C refers to color, anything black or multiple colors. D is technically for diameter, anything over 5 millimeters or the end of a pencil eraser. This is the least sensitive and my least favorite, so I often will tell patients to look for the ugly duckling instead, especially if you have a lot of spots or a lot of moles. Looking for one that stands out from the crowd is usually more helpful. And then E is most important. E is for evolution. And that is a little bit age dependent. Obviously, in a younger population, if a kid gets a mole, as they grow, the mole is going to grow with them. This is often more for patients over 40, at which point you should stop getting new moles. You'll get other spots, you'll get these barnacles, you'll get sunspots. But if you get a new mole, especially a spot that you feel like is changing, you should always get that checked out. Here's a couple pictures. Obviously, this is a pretty obvious melanoma, something you're not going to miss, but sometimes they are a bit more subtle. So the best way is to get a skin exam. If you haven't already, I definitely encourage you to at least go in for a baseline. Doesn't mean you have to go in necessarily every year, but early detection, especially for melanoma, but really all these skin cancers, is going to be most important. And typically when I see a new patient, what brings them in is not actually the concerning spot. We end up finding something else that they had no idea existed. So I would definitely encourage you to get a skin exam if you haven't already. With melanoma, again, here's that keyword, melanoma in situ. When we catch it early, when it's just in that top layer of skin, stage 0, the 10-year survival rate is almost 100%. You compare that to stage 2, which is just the depth of the melanoma, and it cuts in half. So again, catching these early, getting them treated is key. So how do we treat melanoma?
Hey, Nicole?
You have to cut it out. Yes.
Oh, never mind. Corey just answered the question. Never mind. Keep going.
Okay. So with melanoma, you just have to cut it out. We don't use creams. We don't burn and scrape. We do a standard excision, get a good margin around it, and remove all those cancer cells. Sometimes we'll also do what's called a staged excision. That is similar to the Mohs, where we do it in a stepwise fashion so that we can confirm we have a clear margin before we close it. But with melanoma or any pigmented tissue, they have to process it a little differently. It has to process overnight. So staged excisions they don't work for everybody. You have to schedule appointments, Monday through Friday. But it is really helpful in certain areas, again, like the face, or sometimes, what you see on the surface isn't the whole picture. So ensuring that you have everything removed before you close it can be really helpful. And then the last part about sentinel lymph node biopsies, we don't do those in our office. For those, you would go to a cancer center, to a surgical oncologist. But for more advanced melanomas, they will do sentinel lymph node testing and biopsies, and it's more for the prognosis of the melanoma or the staging. All right, most important, how do we avoid all the skin cancer? And number one is sunscreen, and I'll go through some more detail about that. Sun protective clothing is really great. It's come a long way in the last few years. There's a lot more options. If you like to bike, there's certain things you can do for bikes. There's the rash guards for swimming. There's just some lightweight tops that you don't mind wearing more often, and so sun protective clothing can be really helpful. Hats are great too. I'll take a baseball hat over nothing, but a nice broad brim hat is going to give you much better protection. And then sunglasses for your eyes. Seeking shade is helpful. And then trying to avoid peak hours, which often we talk about being 10 to 2, which can be a little misleading depending on where you are or the time of year. So I usually talk to people about looking at the UV index. The UV index is listed on your weather app. If you're looking for air quality, which we're all doing more in the summer now, it's right next to it. So look at the UV index. 0 to 2 is the best time to be outside. Whether you're walking the dog, running, hiking, as much as you can do on those low UV index, the better. And then 3 to 7, it's kind of the medium to high range. You have to be wearing your sun protection, whether it's hat, sunscreen, all of that is needed to protect your skin during those levels. And then extreme, we don't see much on the side of the mountains, but ideally even avoiding direct sunlight altogether, making sure you're doing hat, sunscreen, shade. Again, it's very important for those high levels. I will often get questions from patients, what kind of sunscreen do you use? And I don't recommend a particular brand. We don't sell anything in our office, but there are kind of 3 things I recommend that they look for. One is broad spectrum, so to make sure it protects against UVA and UVB rays. You want it to be an SPF 30 or higher, which I'll explain a little bit more, and then water resistant. And it is important to remember that it says water resistant. No sunscreen is waterproof. So if you are swimming, you need to make sure you're reapplying your sunscreen. So why SPF 30 or higher? It blocks about 97% of the sun's rays when used appropriately, versus SPF 15 only blocks about 93%. Once you get to SPF 50 or higher, it's only about 98%. So there's no problem with grabbing an SPF 75, 80, whatever it is. Just don't get the false feeling that you're extra protected. When you're using 30 appropriately, it really will give you sufficient coverage. And then it's important to remember that no matter what the SPF, you're never blocking 100% of the rays. So that's why we always encourage the hats and shade and avoidance of peak hours, in addition to sunscreen. This time of year, you will often see articles that come out about death screen and the harms of chemicals. And so first of all, what's the difference between chemical and physical sunblocks? The chemical sunscreens work more like a sponge. So they absorb the harmful rays before they can penetrate into the skin. And these have more of the chemical type names, a lot of zones, ones, 8s. Oxybenzone's actually been removed from majority of products that are coming out now because of concerns about the absorption. You'll still see a lot of avobenzone, especially in kind of higher end products where they're less chalky, more cosmetically pleasing. They work well. I'm not personally against chemical sunscreens, but if you don't want to use a chemical sunscreen, there's always a physical sunscreen. And these work more like a shield. So they actually sit on the skin and it helps reflect the harmful rays so they can't penetrate into the skin. And zinc oxide and titanium dioxide are the 2 physical blockers. They do tend to be a bit more white and chalky, which people don't always love, but especially for anyone that's sensitive skin, the physical blockers can be a great option. And then this sounds ridiculous, but how to use sunscreen is actually quite important. Most people don't use it correctly. So you want to make sure that you're putting it on before you even get outside, ideally 15 minutes, but at least time for it to kind of dry and absorb. You need a fair amount to get the actual SPF that's listed on the bottle. So we say 1 ounce, which is about a shot glass or a golf ball size for an adult. And then, as I mentioned, you do want to reapply after swimming. And in general, you should be reapplying every couple hours, which is pretty much everyone's downfall. We get it on, we get outside, and then 6 hours later, you realize you haven't reapplied your sunscreen. So trying to reapply is very important. And I don't question.
I would say we have a question in the chat. I want to know if there is an extra benefit in layering chemical and physical sunscreens.
That is an excellent question. You don't need to layer them. I would say pick one or the other. And then, again, reapplying, like we were just talking about, is going to be most important. The one thing I will say is patients will often ask about spray sunscreens or powder sunscreens. There's a lot of different options now available. Considering how much 1 ounce is to cover your body, I just don't think you get that coverage with a spray sunscreen. However, that being said, they are much easier to reapply and people are willing to use them. So the most important thing is just finding a sunscreen that you're going to use. So I think sprays are fine for reapplication. Again, if you tend to be more sensitive skin, it's not always the best option. But it's, the sprays will work. And my famous line to end today is the best sunscreen is the one you will wear. Doesn't matter if it's $5, $50, chemical, physical, if it's staying in your drawer, it's not helping. So find one that you don't hate, use it, wear that sun protective clothing, especially if you don't want to be reapplying all day, throw on a hat, seek shade when you can, and just every little bit will be helpful. And that is it. Are there more questions? You're free to email me if you have other questions. But thanks for joining today.
And Nicole is located in Seattle and Bellevue. If you guys would like to see her to get your annual skin cancer screenings. We have not found anything that needed to be attacked on me yet, but it is always good peace of mind, especially I am a very moly person who spent most of their life in Seattle. And sometimes you look at a spot long enough that you think it's changing, and it's good to have confirmation that it's not as weird as you think it is. So.
Hey, I have a quick question, Nicole. So pretend you get sunburned. Pale skin like me always get sunburned. What is the after the damage has been done immediately? Do you have any immediate recommendations to I guess the skin's already damaged, but do you have any immediate recommendations for what to do after the sunscreen doesn't
After
work,
a
or you haven't?
sunburn?
Yeah.
Most of it's just symptomatic relief. So, some patients prefer aloe vera. Even just a nice cool cream can be helpful. Ibuprofen for pain and swelling. You can take Benadryl to help you sleep and also for the inflammation. Yeah, at that point, as you said, the damage is done. And also, one thing I should mention is sometimes people will get a sunburn and then they race right into the dermatologist. And it does take a while for that damage to accumulate. So I will still take any excuse for someone to come in and see me, but just know that usually the damage takes a while to accumulate.
That was, for me, it was really interesting to hear what you said about the spray and how much you're supposed to use. A couple weekends ago, I got so sunburned and I had been applying spray, like SPF 50 spray every 2 hours. And I was like, how am I still sunburned? But the amount that you have to use, that's really interesting. So thank you. Super informative.
Yeah. Then we have another question in the chat. Do you recommend going to a dermatologist for skin review rather than just your general practitioner?
It depends kind of on the comfort of your general practitioner. I think most dermatologists have more time. Like in our office, I don't even treat acne. I don't do Botox. So our skin exams are much longer and more thorough than even some of the general derm. And the same goes for primary care. They have a ton of things to be dealing with, looking at. So I don't think it's a bad place to start. And then you can always ask their recommendations if they think you should go see a dermatologist. But I think it does help, again, to at least get a baseline with at a dermatology office, just because that's, they're going to be looking probably for more things, smaller things than the primary care will do.
Is there a certain age that you would recommend starting, like you've got the baseline, but starting doing more regular exams, or is that even a thing?
So if there's a really big family history of melanoma, we have started them in the teen years. It's a little young, but especially if patients have a lot of moles and, again, significant melanoma family history, starting in the teen years is helpful. Otherwise, a good baseline mid-20s. Sometimes I tell parents that are frequent flyers of mine to get their teenager in, more so that they can get a good sunscreen lecture, sun protection lecture from someone other than mom or dad. It's a good time to get that in there, especially before they head off to college. So there's no perfect answer, but especially more moly, definitely start asking with the pediatrician if they think it is necessary. And then by the mid-20s, early 30s, a good baseline check is helpful.
We did have another question. Is the 1 ounce for exposed arms, face, legs, or just 1 ounce for face, body area, or 1 ounce for bathing suit exposed skin?
They say 1 ounce for kind of below the neck. So face, I think, is like a couple teaspoons. But yeah, it does include everything. So you could do slightly less if you're wearing, some long sleeve, some protective clothing. It's a generalization. So someone that's 7 or 6'2" versus 5 foot, it will vary a little bit, but you want a sufficient coverage when you're rubbing it on, so that you can cover everywhere. Make sure you're moving your straps around. That can be a big area for burn. Is they just put it on kind of when they're exposed, just even the strap over, and through the day they end up getting burned along those lines.
All right. And then if the clothing isn't rated for sun protection, do natural fibers or synthetic fibers tend to offer more sun protection?
Yes. So I heard at one study, or at one presentation, they said a plain white t-shirt only had or UPF of 5, which I have a hard time believing. It's pretty hard to even get sunburn through lightweight clothing. There's definitely a huge difference between denim, which is thick, heavy fabric, and a lightweight t-shirt, but you are covered with even just a normal kind of lightweight clothing. I still like a lot of the UPF clothing just for that extra reassurance, especially, if you're in the heat of the day. For kids, they've got a lot better options now. And so I do think the UPF is worth investing, especially if you're doing a lot of outdoor activities. But if it's just a quick trip, here or there, throwing on a lightweight shirt is definitely helpful.
And do you recommend any particular clothing or brand?
For clothing, no. I just ordered my kids some stuff through Hannah Anderson, Ex Officio, REI. There's a lot of options. There's some online ones. Sun Precautions does a lot of sun protective clothing. So no, not a particular brand. You definitely want, it should be UPF 50 at baseline, somewhere up to UPF 100. Or 99. The one thing with the sun protective clothing, it doesn't matter as much for kids because they're going to grow out of it before it wears out. But for adults, if you're going to have it for a prolonged period of time, they will say usually on the label if it's good for 50 washes, 100 washes. So if it's 3, 5 years old and you're wearing it a lot, it would be good to get a new one. All right.
Any more questions in chat if anyone has anything that they're curious about? If you are on a boat and you have on a long sleeve shirt and a cover over your head, is it still a good idea to use sunscreen?
Yes. So when you're either on the water or in the mountains, you're still going to get reflection from snow and water. So I still recommend, even with all your protective layers on, to be putting on sunscreen to help block those reflective rays. Good question.
That's the worst sunburn I've had in my life, is not putting on and getting that reflection back from the water.
Yes,
so
it can be rough.
We do have another one. Mary?
Hi, as a blue-eyed redhead who grew up in Southern California, I assume that I'm going to be, one of the statistics eventually. I wanted to mention to people who are having a hard time wearing sunscreen that you don't have to wear the same kind of sunscreen all over your body. My daughters, who are much more into fashion and makeup than I am, have discovered several varieties of Korean and Japanese and French sunscreen that will apply to our faces because it's got that makeup compatible quality, texture, doesn't leave you feeling super gooey. But then, for instance, on the backs of your hands and your forearms, where you're not so sensitive, you can, goop up with whatever the Walgreens brand 50 SPF is. Um, you don't have to stick with exactly the same sunscreen over your entire body. So, maybe it's worth a splurge for the fancy schmancy makeup quality sunscreen on your face, and then go budget on your on the tops of your feet and your shoulders and all those places that aren't quite so sensitive. So that's my 2 cents.
And Alicia put a great comment in the chat that it is a sunscreen is covered with by your HSA. The fancy tag is covered too. So, okay, well, Nicole, thank you so much for coming and joining us and giving us all this great information.
You are very welcome.
It looks like we had one more last minute question. If one has moles on head, ears, face, neck that are exposed to sun on a regular basis, are they at a higher risk of cancer with those?
No, if it's a benign mole, it does not increase your risk of cancer. Definitely if you've had dysplastic moles, so moles or melanoma, then you are at higher risk. But just having multiple moles in any area of your body does not necessarily increase your risk. All right, if you guys have other questions, feel free to reach out. But thank you for having me.
I'll keep you for just one more second. How do you tell the difference between age spots and cancer?
It can be difficult. So again, that's why it's most helpful to get a skin check. It's usually, sunspots can be really unusual looking, especially when they get more texture and start turning into these little barnacle growths. So there's, aside from looking for the ABCs, that's about the best thing you can do. But don't be surprised if you go in, and the one you were worried about, they say is fine, and then they end up finding something more subtle, because it can be challenging.
Okay, well, thank you so much, Nicole. And then she's got her email address there. And then you can, if she's nearby, you can make an appointment with her or make an appointment with somebody and get your annual skin check.
Thank you.
Bye.
Corey, thank you so much for facilitating. It was really helpful to have somebody answering the chats who knew what they were talking about. Also, that was really helpful. And thanks for making this connection and helping us out. I really appreciate your resource and your facilitation. And yeah, thank you so much, Corey.
Yeah, of course. No, it was fun. It was I love getting to see people I used to work with. It's fun to bridge those gaps. So
yeah. All right. Thank you.
Bye, everyone.
Thank you so much.